On behalf of our team at Eating Recovery Center, we want to thank you for joining us today. My name is Ovidio Bermudez and I serve as Chief Clinical Education Officer for ERC. Each year, we host Eating Recovery Day, always in the month of May. It is a day dedicated to removing stigma, raising awareness, and inspiring hope for recovery. We appreciate your support of this important mission and appreciate you joining us for this educational opportunity. In my role as provider, I frequently get asked, how did this happen to us? How did this happen to my loved one? How could we have avoided this? And perhaps most importantly, what can we do about it now? In this presentation, we will discuss the top 5 things you need to know about eating disorders treatment and that should be taken into account when guiding clinical decisions. Also, we'll talk a bit about how to share this information with families and sufferers to communicate not only the importance of expert care, but also the importance of timely care in order to achieve optimal outcomes. I hope your time today with us is valuable and that you leave here with new knowledge or, at the very least, new language to support the important work that you do all year long. So let's get to the heart of the matter. What are the top 5 things that we all need to know about eating disorders? I've tried to really set this up as 5 distinct points of discussion. The first is to review our current understanding of the etiology of eating disorders based on genetic environment interaction. Second, more than just gateway behaviors, the fact that dieting and excessive exercise have clear neurobiological implications that often trigger and at times cement the disease. Third, full symptom interruption and normalization of weight are key components of any treatment effort. Fourth, early recognition and timely and effective interventions are our current best tools. And fifth, that there is hope. Treatment works, people recover. And I think it's important to believe that, to know that, and message that well. With that said, let's talk a little bit about our current understanding of eating disorders and what we know about genetic environment interaction. This graph is one that I really like. I think it makes a lot of sense. Starting on the left, we really talk about the genetic loading, which can be mild, which can be moderate, or which can be severe. Temperamental characteristics like proneness to anxiety, perfectionism, obsessive-compulsive traits are present usually since childhood. And when they interact, when adolescence comes into the scene, then the hormonal impact of puberty, brain development, stress in the environment, and the impact of culture really interface with our genetic temperamental characteristics. This brings forth what I think is fairly well recognized as a vicious cycle. There is an increased sense of dysphoria, an increased sense of denial, exacerbation of perfectionism, often obsessionality. And what the patient then is looking for is a sense of relief. So pathological eating, the behaviors really in the short term bring about a decrease in the sense of dysphoria. And that is helpful to the patient. So that is the intended consequence. The unintended consequence, however, and what really completes the vicious cycle, is that this brings about neurobiological change that then, in and of itself, sort of supports the increase in dysphoria and sort of the negative life experience, if you will, and voila, there we have it. So what do we know about eating disorders? Well, we know that they're multifactorial. I like this term, biopsychosocial spiritual. The whole individual is involved in this. We know that eating disorders are familial illnesses, that if you have a first-degree relative with an eating disorder, your chances of developing an eating disorder in your lifetime is significantly increased compared to your peers or the general population. We have heritability estimates, and this is an important message for families. Heritability estimates essentially look at what is the influence on the development, the expression of a phenotype, right? When you compare genetically identical, i.e., identical twins, to genetically similar but non-identical, i.e. fraternal twins, for the development of a specific, the expression of a specific phenotype. For eating disorders, we know that the genetic impact is significant. 50 to 80% of the influence comes from genetic, and we'll talk about what's inherited, because it's certainly not anorexia or bulimia directly. But then we have, what is the impact of the environment in this genetic environmental interaction? And so the 20 to 50% that is accounted by environmental influences happens to come from unique experiences rather than shared experiences. And that's really important because the shared experience is really, among siblings, is really the influence, the major influence of the family, of the parenting style, of the interactions, of the history, if you will. The unique experience is how an individual internalizes a particular experience, which means that every person, including those that are genetically identical or similar, are going to experience life in different ways. And hence the notion of genetic environment interaction. Because it's really the data that says that led us to move away from blaming families to joining families as agents of change in the recognition and care of eating disorders. Where does genetic environment interaction come from? This slide shows you the work of Ashraf Kaspi that in 2003 sort of published this really important work that looked at depression, not eating disorders. So in the blue circles we have, they took a group of young women, right, and phenotyped them. In the blue circles we have the group of women that were homozygous for the short allele of the serotonin transporter gene, thus rendering them more genetically prone to experience depression. In the pink squares, we have those women that were heterozygous. They had one shorter allele, one long allele. And in the red triangles, we have the women that were homozygous for the long allele, meaning less genetically prone to depression. And as you can see, when this was tracked according to the significant negative life events that they suffered, at ground zero, at time zero, they didn't separate at all. At time one, when they had a major life stressor, they didn't separate. But as life continued to bring about negative experiences, their genetic potential began to really show up and they began to separate. And those that were genetically more vulnerable experienced more clinical depression. Really important work and very much fitting with what we know about the development and etiology of eating disorders today. So, if it's not anorexia and bulimia that's inherited, what's inherited? Well, we know that there are two things that probably we should pay attention to. One is temperamental traits, and we'll talk about the dimensions of personality, temperament, and character in a second. But the other one, very importantly, is comorbidity, especially in the anxious, depressive, obsessive-compulsive personality traits sort of realms. What's the practical translation of this? These are people. The people most vulnerable to the development of anorexia and bulimia are people who have high stress sensitivity. They're sensitive humans, low distress tolerance, generally speaking, and therefore that renders them vulnerable to either real or perceived experience of stress or injury. In many ways, one would wonder if these are the canaries in our coal mine. We should really pay attention to this because, I don't know if you know the story, but coal miners would take canary in the old days down in a small cage into the mines. If the air became toxic, the canary was more vulnerable and died first. It was then time to get out of the mine for the miners. It was a signal that something was wrong in their environment, and we should really pay attention to that. Here, very briefly, I think just so that you have it, or perhaps for discussion later, are the dimensions of personality, the four temperamental dimensions: novelty-seeking, harm avoidance, reward dependence, and persistence, and the characterological dimensions of self-directedness, cooperativeness, and self-transcendence. Important to keep that in mind. And you can conjure how combinations of these temperamental, characterological characteristics can really determine how we behave and how we experience life in many ways. The prevalence of comorbid disorders and eating disorders is quite significant, it's quite important. And it's important not only because it exists at the time of the diagnosis, but sometimes it predates the diagnosis. We know that for anxiety and depression, about 2/3 of patients with eating disorders get diagnosed with anxiety and depression, and about half of those, the anxiety depression existed before the eating disorder. For obsessive-compulsive types of clinical presentations, about 40%, with 1/3 existing before the eating disorder. For drugs and alcohol, about 1/4. But for people who go on to experience the eating disorder for longer times in their life, is up to half later in life. And for post-traumatic stress disorder types of clinical presentations, 30 to 60%. Why 30 to 60%? Well, probably because the more resistant, the more resilient to the experience of trauma tend to experience less trauma, and the most vulnerable, again, it's sometimes about perceived injury, not about overt injury if you will. So that's important to take into account. What are the environmental influences? We're not going to talk about the models in the magazines. I think we need to sort of distill that into what the environment tends to bring to the table is the thin ideal. Without a thin ideal, right, the natural experiments like the Fiji experiments, the Fiji data, really speak to the fact that without a thin ideal, the development of eating disorders is minimized. If the thin ideal is not translated into drive for thinness, same concept, is a layer of protection. But if a culture sort of internalizes the thin ideal and people develop a drive for thinness, you increase the negative impact of the environment. The dieting mentality is important, it's quite pervasive in our environment, and of course, in the context of a culture of acceleration, comparison, in and of itself, eating disorder, people struggling with eating disorder struggle with comparison enough, but the reality is that we as a society struggle with comparison quite a bit. And I think this all really translates into a sense of pervasive stress. We expect a lot from kids from a very young age. There is a lot of want to be a lot of things that put a lot of pressures on kids, especially when their temperamental characteristics is want to be ambitious and in some ways self-judgmental. So what are clinical opportunities that this translates into? Well, it's really important to identify and to adequately address psychiatric comorbidities as soon as possible, right? We know they're quite prevalent in an eating disorder population. We need to talk about trait management. It's probably one of the best preventive opportunities that we have, is to say, I know my child, I understand this young individual, and there are certain life experiences that may make them more vulnerable to the development of eating pathology. If we can protect them from those, then perhaps we can protect them from an eating disorder. And of course, to manage environmental risk, right? We have in this day and age sort of the example of bullying. If you're in an academic setting that may be wonderful academically, but the psychosocial experience is quite punitive, then we need to rethink, is that the right environment? And think about the amount of criticism and judgment out in the internet, right? I mean, our kids are sort of putting themselves out there. I am not exactly an internet person, but my understanding is that this is a really harsh environment, or can be at least, if you will. So let's go on to the second point, dieting and excessive exercise. What are the triggers? For a long time we talked about tobacco and alcohol as being the gateway drugs. And we know that without dieting, and for some individuals without excessive exercise, the development of an eating disorder is much less likely. So these gateway behaviors matter, and they matter because they have neurobiological impact. They are not innocent behaviors from a neurobiological standpoint. So we know that starvation and nutritional chaos, binging, purging, laxatives, sort of that erratic relationship with the nutrient supply, really affect the brain structurally. We know that. We know that brains atrophy in a state of malnutrition, and it doesn't take long. We know hearts atrophy. We know, there are significant changes to all organ systems, and that does not spare the brain. And also, these behaviors affect the brain functionally. So cognitively, people, as they contend with malnutrition, tend to think differently. Psychologically, they process information differently, and emotionally, they tend to feel differently about things. And I think for most of us and that have sat and had a conversation with somebody entrenched in their eating disorder, all these areas become self-evident. They're clear in the context of that interaction. What are the overall implications of the gateway behaviors? Well, starvation triggers a neurobiological response. If you throw excessive exercise on top of that, which exacerbates or exaggerates the starvation, then this adds to the stress response that the system has to contend with. If the patient also is binging and purging, then there's additional neurobiological coping strategies that need to brought into the picture to sort of cope with the insult. Essentially, our physiology has shifted from thriving mode to survival mode, and our brain pays a price for that. It's a sacrificial stance, sort of a live to fight another day stance. What are the altered nutritional status? What are the neurobiological responses that it brings? Well, it's interesting because the intent of the response is to aid survival. right? So for a particular individual, that may indeed be the case. However, when we think about the group, when we think about the heterogenic response of human beings, then for some people, this actually is quite detrimental. So as we starve, we recruit adaptive stress responses, right? Our brain goes into alarm mode, survival mode. This tends to exaggerate temperamental characteristics. So, if you're a pretty relaxed individual, right? As you starve, you should become more anxious, more obsessive, and be very willing to look for food. However, if you're already a pretty anxious and a pretty obsessive individual, the positive adaptive value really is there for the many, but may be negative for the more vulnerable ones. Hence the notion of the genetically loaded and temperamentally vulnerable are the people who are more likely to have the most negative neurobiological response to a brain experience like this. So coming back to our graph here, I think I mentioned this. What the patients are looking for with the pathological eating behaviors is a decrease in dysphoria. They want to feel better, and temporarily that for many actually does. The unintended consequences, the neurobiological change that then tends to cement the behaviors and bring about the vicious cycle, brings about the repetitiveness of this cycle. All right, let's go on. Number 3, full symptom interruption and normalization of weight become key components in any treatment effort. I think we came from a time in which, we wanted to settle patients in. We at times prioritized the therapeutic relationship. We wanted patients to find safety. But the truth of the matter is that we need to rethink that based on what we know is happening neurobiologically when a brain is marinating in sort of this negative survival stance, if you will. So as we restore weight to the patient, what we're after is putting on weight back. The reality is that we probably should think about and talk about that in a very different way. So initially, as we restore weight, we're correcting the abnormalities related to organ system dysfunction when we're in that survival adaptation stance. So the system makes sacrifices to survive, and organ systems deteriorate and function, pay a price for that survival. So as we refeed, we want to bring back, we want to uptick the functional capacity that these organ systems have sacrificed, if you will. A big important task is to switch off starvation signaling. As the body perceives starvation, the reality is that it will continue to put up its guard and continue in that survival stance. Provide substrate for tissue repair, which is quite important. Not everything that we eat as we refeed goes into putting on weight. A lot of it goes into repairing cellular damage and repairing tissue damage. Promote improvement in organ system functions, because that in and of itself is part of the signaling that we're getting out of starvation. And of course, switching off catabolism back to a stance of anabolism, meaning that we can build, strengthen, condition, support more adequate organ system functions. And the goal there is to normalize weight, and the best data supports a consistent weight recovery trend. Hence, the whole notion that in FPT, for example, right, if the weight is not coming on after a few weeks of treatment, we really need to rethink is this the right path at this time for this individual. Later, as we continue weight restoration, our goals become turning off chronic stress response, lowering cortisol levels, normalization of the hormonal milieu, hence the significance of the resumption of menses for young ladies, for example, normalization of body composition, being fatty enough, owning enough body fat to support body system functions, including brain function, and of course catch-up growth and development when that is important. In weight restoration, the perpetuation of an underweight state, which in essence to the system implies insufficient energy availability, will keep the brain trapped in this vicious cycle of neurobiological dysfunction. The unintended consequence sort of completes the cycle and keeps it rolling circularly and tightly. When we discuss then or think about the interruption of compensatory behaviors, binging, purging, laxatives, etc., I think the message is similar. The perpetuation of binging, purging, or any form of compensatory behavior, which really implies to the system nutritional chaos, unsafe food supply keeps the brain trapped also in this vicious cycle of neurobiological dysfunction. The interruption of these behaviors tends to incentivize the brain to look for alternative mechanisms for the relief of dysphoria. So now rather than falling into a dysfunctional way of relieving dysphoria, we can find more adequate ways of relieving dysphoria, meaning potentially less harmful and more adaptive mechanisms to address this. So that becomes important. What are the practical implications? Well, eating disorder treatment effectively cannot happen off the wagon. If the patient is restricting, binging, purging, compensating, overexercising, I don't think that the brain is positioned to take on the process of change, to effectively manage a process of change. Psychological and physiological improvements thus need to walk side by side. We need to be paying attention to both in whatever treatment setting or environment, whether this is outpatient, partial hospitalization, residential, inpatient, even for critically ill patients, that's important as well. Environmental changes needed must also be addressed. So we just can't expect that we're simply going to bring this individual back to where they were physiologically and sort of land them in the same genetic environment interaction. That's not likely to be conducive. We need to be thoughtful about that. So in my eyes, success implies comprehensive treatment from a biopsychosocial spiritual perspective, really looking at, understanding, and treating the entire individual and their context. Apropos to this, we often talk about brain atrophy. And an important question for families is, will my loved one's brain grow back? And the answer is yes, but not exactly how one would expect. So I think there are a few caveats that are important to think about, and what I've done here is summarize my understanding of the literature for you, just to distill this information. So normalization of brain matter after a starvation insult can be guided by the following data. About 1 year after weight normalization, there is partial regrowth of brain atrophy. Actually, if you scan the brain by CT scanning, for example, you will see recovery, full recovery of brain volumes. However, white matter tends to recover earlier than gray matter, and there tends to be a lag in gray matter recovery, right? So the gray matter that has been lost, both in neuron number and interconnectedness density, is still lacking a year later, even if your weight has normalized. 3 years after weight normalization, however, the structure of the brain seems to fully normalize. Both gray and white matter components seem to really come back, but it takes sustained adequate nutritional status for that to actually be the case. However, if the structure of the brain normalizes, functional deficits may persist if, for example, and this is the data available, this should be identical for young men, if menses have not also normalized. There is a complex interplay between weight status, normalization of stress responses, i.e. cortisol levels, and global hormonal well-being for optimal brain function, and perhaps that this is even necessary for ongoing brain maturation when we're talking about young brains. So weight recovery alone, in and of itself, is really important, but it may be insufficient, and recovery from a nutritional insult may really require adequate body composition and normalization of hormonal function to support optimal brain function. Meaning that what we're really after is not to get you back to a weight, what we're really after is to get back to an all systems go neuroendocrine environment supported by optimal nutrition and optimal weight status, so that we can get back to the business of thriving as a human being. Hence, I think we have an opportunity here to really shift the language from nutritional rehabilitation, weight restoration to brain rescue. And if the brain is sitting in a negative marinade, I think it behooves us to reach in and really pull it out so that the brain can get back to its full capacity to support normal growth, normal development, normal function. Let's go to our fourth topic. Early recognition and timely effective intervention, really our current best tools. And I want to underline the effective part, because I think that there have been times historically that as a field we have felt like we're intervening, and yet I think we need to really lean on the best available data to say we're not only intervening, but we're effectively intervening to the best of our ability. So early recognition and timely intervention, what does it bring to the table? Let's go through this slide. I really try to put it in one snapshot so that it could be better digested, so to speak. So we can avoid unnecessary medical workup, right? The notion that, oh my gosh, this young person is losing weight or not growing, and what's wrong with them medically? What's the medical mystery? If we recognize this as eating pathology, as an eating disorder or a developing eating disorder, we can avoid a lot of x-rays, a lot of tests, a lot of pain, really. Early recognition and timely intervention can help us have patients respond in a less restrictive setting. For example, FPT, right? So the earlier we enter a young person in the development process, the more likely they're going to respond on an outpatient basis to an FTT type of model. Minimize interruption of psychosocial development, i.e. interactions with friends, with school, interactions with the family that are quite important. Easier to renormalize neurobiology before neurobiological change has had a chance to cement, right? That vicious cycle is self-reinforcing. So the more time you spend sort of spinning, your brain spends spinning around this, the more likely it is that is harder to break away from that cycle. With interruption of neurobiological derangement, risk for the evolution of comorbid vulnerability may be partially or at times totally evaded. So if somebody is going to develop a panic disorder, or if somebody is going to develop major depressive disorder, if we and that is brought about or at least triggered in part by the nutritional insult, then by pulling them back from the nutritional insult, we may save that brain deterioration from that mood perspective. Growth impairment and other organ system dysfunction can also be prevented, right? We see a lot of kids with a lot of heart damage and liver damage and bone damage and growth damage. And certainly early intervention, early effective intervention can change the course of that. So what I like to float out there for us to take home is, look, recognize an eating disorder when you see it and implement the most appropriate care for the needs of the patient expediently and decisively. This notion of, I've never seen a dream trip for a kid or a family in the throes of the evolution of an eating disorder work out. Not one. And of course, they're all undertaken and in some way sanctioned by us with the best of intentions. So expediently and decisively, I think are important words to keep in mind. And let's get to our fifth agenda item. There is hope, and treatment works. And I think in many ways, this is an area in which hope is not always evident. So it's really important for us to be the ones that can see it, that can feel it, that can believe in it, and keep working towards it, because that's really important. The truth of the matter is that the majority of patients with eating disorders, the vast majority that receive treatment, the truth is we know very little about the natural course of the disease when patients have not accessed treatment. But those who do access treatment improve or fully recover. We know that roughly 30% are well in about 2 years after the onset of their illness with treatment. Another 60% on top of that are well or improve in 3 to 10 years. It's not a timeline that families always like to hear. But there is, I think, a reasonable explanation for this that we'll get to in a minute. And we know that about 10% do not respond to treatment or go on to chronicity. That's a group that we need to understand better, because it's probably the group that we understand the least. So the potential for brain maturation will improve the likelihood of recovery. So many patients, I don't think it's coincidence that most patients that develop eating disorders develop them in their adolescent years, and there is a very important window of hope for recovery in the mid to late 20s that coincides with full brain maturation. So to me, it's really about recognizing it, keeping that brain as functional as possible so it tends to not detour, at least not go on long detours from normal development, which can then bring them back on track to find a better likelihood of full recovery as brain maturation in the mid to late 20s really comes to bear. Is it a long time to live with an eating disorder? Sometimes, yes, it is. But I do think that in the meantime, if we maintain patients medically and psychologically safer, then functionality and better enjoyment, a better experience of life can continue. I do want to share with you, courtesy of Dr. Craig Johnson, a couple of slides about most recent data about long-term outcome, both for anorexia and for bulimia. This is data compiled from Steinhausen, from Kiel, and from Eddy. And as you can see, The percentage of patients that are recovered after 10 plus years of illness for anorexia is 73%. That our recovery is 73% for all eating disorders. For all eating disorders improved is 82%, and the chronicity seems to, at 10 years, seems to land in that 18% sort of window. So not very different from the way that we've been thinking about this. If we stratify this according to diagnoses, anorexia, bulimia, and binge eating disorder, we can see that at less than 4 years, binge eating is more responsive than bulimia, and bulimia is more responsive than anorexia. In the 4 to 10 year window, then binge eating and bulimia are as responsive, and there is an improvement in the responsive rate of anorexia, but it still lags behind. And then 10 plus years, we lag the data for binge eating disorder, but you can see that the response likelihood of anorexia sort of matches and at least numerically surpasses that of bulimia. So whether you have anorexia, whether you have bulimia, whether you have binge eating disorder, we know very little about ARFID and long-term outcome. The truth of the matter is that it's important to hang in there and really hold on to the hope. So I'd like to summarize our conversation today with making a little bit of commentary about the 5 points, the 5 things that I believe we all need to bring to bear when we want to understand and care for individuals suffering from eating disorders. So I want to summarize for you what we have discussed today, the 5 points, the 5 things that I believe we all need to bring to bear as we care for, understand, diagnose, and treat individuals suffering from eating disorders. Number 1, the etiology of eating disorders is complex. We need to be able to understand, work with, communicate about genetic environment interaction, and really view these illnesses as true biopsychosocial spiritual illnesses and come at it from that perspective, from that model. We have to take the whole individual into account. 2, gateway behaviors are not neurobiologically innocent and can cause significant impact, especially for the more genetically, temperamentally vulnerable. 3, full symptom interruption and weight normalization, not weight approximation, but weight normalization are key components to any treatment effort. In other words, if the food supply seems unstable to our system or the environment appears to be unsafe, then physiology will remain in survival mode. Weight recovery should really be languaged as brain rescue, and normalization of brain function after a nutritional insult requires 3 years of nutritional stability. So it's really important not just to get back to weight normalization, but to maintain adequate nutrition and to maintain adequate normal weight. 4, early recognition and timely, effective intervention are best current weapons. Education of the public and healthcare providers in general are therefore a must. And 5, 85% of people with an eating disorder will recover fully or improve over time. But expectations about the course of illness may be longer than most families would like. So as clinicians, we need to be the holders of the hope. It's one of the most important things that we can bring to the table as we interact, interface, get to know, and care for these families. Thank you.
Eating Recovery Center's mission is to provide the very best care to patients, families, and providers of care in the treatment of and recovery from eating disorders and related conditions.